We are very thankful today for our sponsors. I hope that you've had a chance to chat with our vendors, to Acadia, Supernus, and Amneal, who help to make sure that we're able to put on these events and they're at no cost to you all. At the Parkinson's Foundation, we are the nation's leading community for people living with Parkinson's, those who love them, and those who are working to end the disease. We have all sorts of resources. I know that when I listened to registration, many of you said you had a lot of our resources, which makes my little Parkinson's heart so happy to know that there's so many of our stuff already in your homes. We work to end Parkinson's for today, for tomorrow, and for us all. We work under three sort of main pillars. The first one is our research. So we work to help find research to better understand Parkinson's. We are involved in Parkinson's virtual biotech. So looking for resources and looking to discover treatments in years, not decades. And then we also have our landmark study, PD Generation. You might have heard about PD Generation before. It's this really incredible study that offers genetic counseling to anyone with a Parkinson's disease diagnosis. You can participate at no cost. You can do so in person or at home. There's an at-home option as well. To participate, you can check out our website, parkinson.org/pdgeneration. This will be one of those links that I send you next week or so. And go through a short intake. Once your results are done, the most incredible part of this study, I think, is that you'll get your genetic results and you'll have a genetic counseling opportunity to go through those results with a genetic counselor. You may or may not know this, that genetic counseling costs gobs and gobs of money otherwise, and this is available to you for free. We also have our global care network, of which the University of Michigan is one of our centers of excellence, which means that they meet rigorous, comprehensive criteria to maintain the utmost education and service for our folks with Parkinson's. In the Great Lakes chapter, which is what I represent, the whole state of Michigan and the state of Ohio, which I think is hilarious that they give me both of those, but we have four actually members of our global care network. So University of Michigan here in Ann Arbor, Corewell Health, and the Ohio State University are both comprehensive care centers, and the Cleveland Clinic is another center of excellence. So we are well resourced here in the Great Lakes chapter. And then finally, before I introduce our first speaker, just another word about our resources. So a couple of things that I will highlight for you. The first one is our hospital safety kit. If you're not familiar with that guide, there's a copy, a display copy on both of those registrations tables when you first came in. Those are for planned or unplanned visits to the hospital to help you advocate for yourself or your loved one in the hospital. So it goes through the 5 Parkinson's needs. There's homework in those packets. So if you order one or you get one from us, don't just put it on your shelf and say that you'll read it later. You actually have to fill it out. You got to go through your medications. You have to take it to your Parkinson's doctor and have them sign a sheet. It's a whole thing. But that is meant to help you to be better equipped to advocate for good care in, again, planned or unplanned visits to the hospital. The second one that I will highlight is brand new this year. It's our Care Partner Guide. If you've been around Parkinson's and the Foundation for a while, you might remember our Care Partner book that was like really thick. This is the updated version of that, has all sorts of information for care partners because we know that our care partners play such a vital role in care for our folks with Parkinson's. So if you don't have either of those, come and see me. We can get those ordered for you. They'll ship out to your house for free. There's other host of information that we're available for you. And I hope that you'll take with you the resources that are on your table today as well. I hope that they make it to your home, partially so that they don't come back to my home. So with that, I will, do you want to do anything else? Yeah, go ahead.
Hi, everybody. Thanks for coming. I just wanted to thank everybody for allowing us to share your registration information. That will allow us to send you emails from the Michigan Medicine Center of Excellence. We have a newsletter that we send out quarterly, and we'll also send an email alerting you when the videos are processed and up on our website. And we are going to cross-share, so they'll be on both of our websites. So just so you know, you'll be hearing from both of us.
Thank you, Laura. All right, and with that, I will invite our first speaker up, Dr. Mark Garwood. He is an assistant professor of neurology at the University of Michigan, completed his medical degree at Loyola University of Chicago, and residency in neurology at the University of Iowa Hospitals and Clinics. He completed his fellowship in sleep medicine at the University of Michigan and is board certified in sleep medicine and neurology and sees patients at Michigan Medicine. Thank you, Dr. Garwood. Oh, and we're going to turn the lights down now, so don't anybody get scared.
Well, and thank you, Laura, and thank you to the Parkinson's Foundation for inviting me here. What a wonderful community, and what I want to do today is to talk about Parkinson's disease and sleep, and see if we can learn some things together that will hopefully help you with your own sleep if you have Parkinson's disease, or help you help someone else with Parkinson's disease to sleep better. So some goals for the talk today. I first want us to, we'll review a little bit about Parkinson's disease in general and symptoms that are associated with Parkinson's disease so that we can discuss how those symptoms and some of the condition itself can impact sleep. And then I want to review some non-movement related symptoms of Parkinson's disease and how they might be affected by disrupted sleep, and which can certainly be important, including if there are symptoms involving mood, symptoms of troubles thinking, or balance, and how those things can all be impacted by disrupted sleep. And then again, really ultimate goal is to be able to improve your sleep or help improve someone else's sleep that has Parkinson's disease. So Parkinson's disease, so many of you may know this, but it's an adult onset progressive neurodegenerative disorder. So that a lot's packed into that. So progressive means it would gradually and does gradually worsen over time. Neurodegenerative means there are neurons in the nervous system that are basically losing their ability to do their jobs. So the average age of onset of Parkinson's disease is about 70, and the incidence of Parkinson's disease really starts to increase over the age of 60. And if we look at a group of people that are 40 years and over, about 3 out of every 1,000 of those folks in the world we estimate would have Parkinson's disease. So as we get older, it's not a rare condition. So as I've mentioned, it's going to typically affect folks that are older, in age, and at around that same time, there are also some sleep changes that can affect us with normal aging. So as we get older, there's a tendency to have reduced slow wave sleep or deep sleep. There's a tendency to fall asleep a little earlier at night and wake up earlier in the morning. There's a little bit of increased fragmented sleep, so sleep's not as deep, and it can be a little harder to fall asleep. So those things are common with normal aging, and Parkinson's disease commonly can affect us as we get older. And then obstructive sleep apnea, which we'll talk about a little bit later, and insomnia, those are common sleep disorders that are more common in seniors than in younger adults, but everybody can have trouble sleeping at any age. So in terms of the disease process of Parkinson's disease, basically, we used to think of it, and we still do, as a condition where neurons that make dopamine don't do their job as well, and those neurons start to lose their ability to do their job and degenerate. And there's a slide depicting that in the upper right. You can see a neuron that's healthy, and you can see sort of dopamine in between kind of an end of a neuron and another. And then below that, you can see kind of a degenerated neuron with less dopamine, less neurotransmitter. And in this part, I'm going to walk over here. This part right here is called the substantia nigra. And the color down here is decreased compared to above, and that's a place where we make a lot of dopamine. It's a place, part of what's called the basal ganglia. So over time, that can change in Parkinson's disease, and for the longest time, that was what we really thought was the main culprit in Parkinson's disease, and we still do, but more recently, in the last 10 years or a little longer, we've learned that there are other neurotransmitters besides dopamine that are affected in Parkinson's disease, and we also are starting to appreciate there are other non-motor symptoms that can be a result of those neurotransmitters. And we'll talk about what some of those non-motor symptoms would be. But we think it's depletion of dopamine and other neurotransmitters that can lead to both motor and some non-motor symptoms of Parkinson's disease. And then we still don't know exactly what the real underlying cause or trigger is to get neurodegeneration started in Parkinson's disease. And we also don't fully understand yet the cascade of events that leads to the neurodegeneration once it starts. But we think in the end, it may involve an abnormality in protein processing. There's one specific protein, alpha-synuclein, and we think that misfolding in it and aggregation and toxicity eventually may lead to symptoms, or that might be a byproduct of the neurodegeneration. And that alpha-synuclein is found in structures called Lewy bodies that we've seen with Parkinson's disease for a long time. So there are a couple slides depicting Lewy bodies. I'm just going to go over here, and it'll help keep me awake moving around. But this is a picture of a Lewy body that's pink up here and down here brown with different stains that help us look for Lewy bodies under microscopes. So clinical manifestations of Parkinson's disease, kind of classic motor symptoms that many of you may know, but just to have everybody on the same page. So it can often cause a resting tremor more than an action tremor. Sometimes in neurology, we will refer to it as a pill-rolling tremor, where kind of between the thumb and the index finger, it almost might look like someone's trying to manipulate a small object, like a pill. There's slowed movements and movements of decreased amplitude. We can see rigidity where there's resistance between muscles involving the passive movements in a joint, and some postural instability that can increase the risk of falls. That tends to get worse with more advanced Parkinson's disease. And those are kind of the main cardinal symptoms of Parkinson's disease. And those symptoms I would refer to as Parkinsonism. So Parkinson's disease, that's the most common cause of that group of symptoms that I mentioned, but there are some other causes of Parkinsonian symptoms. So Parkinson's disease is one neurodegenerative condition, but there are some others. There's a condition called Lewy body disease, another condition called multiple systems atrophy, and a condition called progressive supranuclear palsy that are different causes of Parkinsonism. They'll look a little different than Parkinson's disease to the neurologist, but they'll have some similarities. And then there can be secondary forms of those Parkinsonian symptoms, such as after a stroke or occasionally a medication side effect. So Parkinsonism can have different causes. Parkinson's disease is the most common one, and the treatments can differ a little bit based on that. But out of that group, Lewy body disease, Parkinson's disease, and multiple systems atrophy have something in common, and that alpha-synuclein protein is abnormal in that whole group. So there might be some similar treatments and maybe a similar cause within that group involving those three conditions that look clinically different, and they are different as well, we think, when we study the conditions in terms of what's happening. So there are some other motor manifestations besides what I mentioned earlier. So we'll often see like a little bit of a decreased facial expressions with Parkinson's disease. We'll call that hypomimia. There can be a decreased eye blinking rate. Sometimes words can run together a little bit, and speech can be softer. Dysphagia refers to trouble swallowing. We can see that in Parkinson's disease, and sialorrhea is excess salivation that we can see as well. Not everybody has all these symptoms, and they can vary from person to person. There can be some visual changes where there can be some blurred vision, some trouble sometimes being able to see different contrasts, and occasionally some troubles holding eyelids open. That's not as common, but some of these things, again, could occur with Parkinson's disease and because of it. And then there can be musculoskeletal changes, like a stoop posture. There can be some changes to the curvature of the spine that we can see with Parkinson's disease, and sometimes muscles can contract, which is called dystonia, or it can be dystonia. And then there can be troubles with walking, where there can be shuffling gait. There can be some short-stepped gait, freezing, where somebody might lose their ability to walk suddenly, and sometimes the walking might appear quicker with each step, called festination. And those are all motor manifestations of Parkinson's disease. So on this slide, in the middle, I know a table in the back, they may know who that is, but I bet they do. So that's and many of you may, that's Muhammad Ali in the middle, who had Parkinson's disease. Next to him is Sharon Stone and Diana Ross, and that was a fundraiser that he was involved in for Parkinson's disease. But if you look at his face, it's a little bit masked and less animated than he was before he had Parkinson's, just in appearance only. And then this is a diagram depicting some of the motor manifestations of Parkinson's disease, where there may be a masked face, a tremor in the arm, and where it can cause a shuffling gait, and potentially some rigidity as well. And when someone hears Parkinson's disease, even many physicians, that's often what we think of first. We think of these motor manifestations that are easy to see, maybe easier to see and easy to recognize. But there are many non-motor symptoms that can affect Parkinson's disease. So sometimes there can be some cognitive symptoms, and that can be a continuum. So early on, sometimes there can be some subtle organizational troubles or just recognizing things in space that can happen. Again, they don't happen to everybody. And if Parkinson's disease is advanced, there can be some troubles with memory. Occasionally, especially due to medicines, there could be a risk of seeing or hearing things that aren't there, or believing things that aren't true. Again, doesn't happen to everybody. Some medicines could make that happen more. There could be some mood changes, where there could be a decreased mood or depression, or more worrying, anxiety, or sometimes harder to initiate activities. We can see those with Parkinson's disease more commonly than other conditions. And then certainly trouble sleeping and fatigue. That's what I want to focus on today. We can see autonomic troubles, where there could be like dizziness or lightheadedness, occasionally urinary or sexual troubles, loss of smell. We can see with Parkinson's disease, constipation can be a common symptom. There can at times be pain, not commonly, but we can sometimes see a polyneuropathy we've learned more recently can be associated with Parkinson's disease. It could cause pain in the extremities. And then there can be some skin findings that aren't as common, but a certain skin finding called seborrheic dermatitis, and there's a small increased risk of melanoma in Parkinson's disease, and increased sweating as well that could happen. So of the non-motor symptoms, again, I wanted to focus on sleep today. And problems with sleep, we think, are among the most common non-motor symptoms in Parkinson's disease. And they have important consequences. They can cause a reduced quality of life for patients or their caregivers. And if we don't sleep as well, our balance isn't as good, and our thinking isn't as clear, and that can also worsen factors in mood. So sleep's important for all of us. And especially if we might already have some troubles in those areas, sleep's even more important. And then sleep gets a little bit challenging in Parkinson's disease. In part, Parkinson's disease can overlap in terms of demographics with normal aging. If Parkinson's disease is affecting us when we're maybe more in our 50s or 60s, and sleep's a little bit more vulnerable then too. Also, some medicines that are used to treat Parkinson's disease can affect sleep, and there are other symptoms of Parkinson's disease that can affect sleep that we'll talk about that are important to recognize so that we can try to get sleep better. So today I want to focus on 6 main sleep disorders or conditions that can get impacted with Parkinson's disease. The first that I want to talk about is a condition called REM sleep behavior disorder. And then I want to focus on insomnia, and then a condition called restless leg syndrome, and then talk about circadian rhythm disorders, then focus on a breathing disturbance called obstructive sleep apnea, and then talk about excessive daytime sleepiness. All sleep disorders or sleep-related symptoms that are common in everyone, but especially common in Parkinson's disease. So REM sleep behavior disorder is a parasomnia. So a parasomnia, that refers to an abnormal behavior or a sensation that occurs during sleep or a specific sleep stage or a change of sleep stage in sleep. And in REM behavior disorder, the individual who's sleeping will act out their dreams. And this occurs because normally we have paralyzed muscles when we dream, but in REM behavior disorder, that paralysis of our muscles that prevents us from acting out our dreams is basically broken, and that can cause somebody to vocalize or act out their dreams. Now, when this occurs, these movements, they can be of violent nature, and that could certainly put the individual with Parkinson's disease at a risk for injuries or potentially their bed partners. Eyes are typically closed when this happens. It's uncommonly associated with sleepwalking, so generally the behaviors are confined to the bed, but somebody could fall out of the bed with these behaviors. And generally, this does not disrupt the sleep of the individual that has REM sleep behavior disorder. It could disrupt the sleep of a bed partner, but generally it's not a cause of sleepiness for the individual that has it. So on this slide, I have a couple images of what I would see if I looked at an in-lab sleep study of somebody and what we're looking at, and I wanted to show those to you. So on the left, up high, we have an orange arrow, and that orange arrow is pointing at eye movements that we can recognize on a sleep study. So that's dreaming sleep, which is called REM sleep, or rapid eye movement sleep. Below that's circled, those are called sawtooth waves. That just helps a sleep physician recognize when someone's dreaming. So we can tell that with an in-lab sleep study. And the blue arrow is looking at muscle tone in the chin, which is very flat, hard to see, and that's normal. Our muscle tone goes down when we dream normally, and that's what we should see. The slide below it is not dreaming sleep. It's a stage of sleep called stage 2 sleep, and that's just up here because the chin tone is a little bit higher, but also still really low. And then next to that is a REM sleep in somebody with REM sleep behavior disorder. So there, the orange arrow is looking at the muscle tone in the chin, and it's significantly increased compared to the other slide. And below it, where there's this black activity with this orange arrow, those are muscle movements in someone's arm and leg that are happening when someone's eyes move. So normally that wouldn't occur. Somebody's paralyzed in dreaming sleep, but with REM behavior disorder, there can be loss of this paralysis in movement when someone sleeps that we can recognize on a sleep study. So REM sleep behavior disorder, it requires, for definitive diagnosis, 2 or more episodes of dream enactment behavior that we don't think is from something else, and to have a definitive diagnosis recognizing this REM sleep without atonia on a sleep study. We could still diagnose somebody as having a probable case of REM sleep behavior disorder, or what we might call provisional REM sleep behavior disorder, if they didn't have a sleep study, because it may not always be needed or always be practical just for this condition alone. But this has become very important to us in sleep medicine and in Parkinson's disease research. So we think REM sleep behavior disorder is a highly specific feature of what we call prodromal Parkinson's disease. So something that's prodromal is basically something that's occurring early on before the main condition arrives. And we now think that if somebody has REM sleep behavior disorder, there's a fairly high chance that they might go on to get Parkinson's disease. And we can, though, see REM sleep behavior disorder from other causes. So especially in somebody that's 50 or over, men more than women, REM behavior disorder could indicate a really fairly high risk of getting Parkinson's disease. But with younger ages, we can see it from other things, including there are some antidepressant medications that can potentially cause or worsen REM behavior disorder. Not everybody with Parkinson's disease gets REM behavior disorder. We think it affects about 60% of folks with Parkinson's disease. treatments, melatonin can be very effective, often at pretty high doses, higher than what somebody might typically take or what a doctor might have somebody take to help sleep. Sometimes doses as high as 18 milligrams are used. And that's really the medicine or treatment of choice for the condition. A prescription drug called clonazepam can be effective, but that could have some balance troubles or possibly thinking troubles, so we're a little careful and judicious in choosing that. There are some medicines that can aid memory called acetylcholinesterase inhibitors. An example of one of those is donepezil, which is Aricept. It's thought that that might help REM sleep behavior disorder. And then safety measures are important, which we'll talk about. And then if somebody has obstructive sleep apnea, treating their obstructive sleep apnea with CPAP might help their REM sleep behavior disorder. So some important safety measures. It's important to make sure that nightstands or anything with sharp corners are away from the head of the bed. Trying to have any padding of sharp corners or moving furniture, if it would certainly be near the head, would be important. Lowering the bed can be helpful. Sometimes a padded headboard, padded bed rails, or padded floor might be needed if the episodes are happening frequently. It would be very rare to do something complex involving a weapon in somebody's sleep that's acting out their dreams. But out of the abundance of caution, and so the sleep physicians can sleep, we will say remove weapons. We remove weapons from the bedroom, although it would be very rare for that to occur where there could be something that complex. And then we'll have somebody potentially, if the episodes are really severe and not getting better, we may need some barriers in between bed partners or possibly even having the bed partners sleep in another room. So I mentioned this concept of prodromal of a prodromal syndrome. So there are some other prodromal symptoms in Parkinson's disease besides REM sleep behavior disorder. These are symptoms that can occur as part of Parkinson's disease before we see the classic motor symptoms of Parkinson's disease. So REM sleep behavior disorder is one, but we think constipation, which is not specific, a lot of folks might get constipation, but we think in Parkinson's disease that could be something that could be occurring earlier on. Loss of sense of smell we've recognized also could be a prodromal symptom. Other non-motor symptoms like urinary urgency, possibly sexual dysfunction, depression, anxiety, some color vision changes, and sometimes some subtle thinking changes might occur early on. But these prodromal symptoms, including REM behavior disorder, they may predate many of the motor symptoms of Parkinson's disease, sometimes by up to 10 years. And this is important because we've recognized this as a possible window of opportunity for disease-modifying medications that we might be able to give somebody that might prevent Parkinson's disease or modify the course of the illness. And this also may allow some patients to participate in clinical studies early on to help us learn more about the disease, or hopefully to be able to offer an antidote or a treatment very early that might slow the progression of Parkinson's disease significantly. And then if we had somebody with REM sleep behavior disorder that didn't have a diagnosis of Parkinson's disease come to our sleep lab, or we identified them in sleep clinic, so I would be wondering, could they get Parkinson's disease? And especially most men greater than 50 that have REM sleep behavior disorder, we think will get an alpha-synucleinopathy. So either Parkinson's disease or Lewy body disease or multiple systems atrophy that are also in that class. One study thought that the risk of developing one of those would be about 75% in somebody that's 50 years or older that has REM sleep behavior disorder. There's other studies have suggested even possibly a higher rate, maybe 85%. And then one study that looked at autopsies found about 95% of REM sleep behavior disorder patients had these synuclein deposits that they could identify, suggesting that maybe even a higher amount of folks with REM behavior disorder that might be really tied in to these alpha-synucleinopathies. A lifetime prevalence of Parkinson's disease, again, is about 1 out of 1,000 or 2,000, so it's showing you that, certainly with REM behavior disorder at an older age, there's a much higher risk that we need to be watchful of, and potentially a way that we can intervene early as we get an antidote or early treatment that we can offer that's neuroprotective. REM behavior disorder exists in about 90% of folks with this alpha-synucleinopathy called multiple systems atrophy, about 80% of folks with Lewy body disease, and then about 60% of folks with Parkinson's disease. And then there's a concept called prodromal REM behavior disorder. So that is possibly subtle signs of REM behavior disorder that we see on a sleep study when someone actually hasn't, when we're not aware of them acting out their dreams yet. So for example, seeing more muscle tone than we should on a sleep study, or seeing subtle movements but where they're not acting out their dreams, that might occur before clinical REM behavior disorder. So I wanted to switch gears now and talk about another sleep disorder, insomnia, which is common. This can affect everyone and really commonly will affect all of us at some point in our lives. So insomnia, what is it? It refers to difficulty falling asleep, so we'll call that sleep initiation insomnia, or staying asleep. We'll call that sleep maintenance insomnia, and it can and there can be troubles waking up early in the morning and having difficulty returning to sleep after that, despite an adequate opportunity to sleep, that will cause impairment in daytime function. Insomnia can kind of exist on its own. We'll call that primary insomnia, or it can exist secondary to something else. And it can be acute, or it can be chronic. We'll call insomnia chronic if it's lasted for more than 3 months. And then we define chronic insomnia as it taking longer than 30 minutes to fall asleep, or being awake for more than 30 minutes after someone's fallen asleep, for greater than 3 nights per week for more than 3 months. But certainly this is all within a spectrum, and there could be some degrees of trouble sleeping that are more in someone than someone else that are causing them some troubles. So insomnia is very common in Parkinson's disease. It affects about 80% of Parkinson's disease patients at one point. Sleep maintenance insomnia is more common, so staying asleep is more common than troubles falling asleep, though both can happen, and it can change in an individual, and they can occur separately or together. And then we think many factors contribute to insomnia in Parkinson's disease. And most factors would be more common in advanced Parkinson's disease, but we can see them all generally in early stages as well. And the cause of insomnia or etiology of insomnia may vary over the course of the disease. And then the treatment for insomnia really depends on the underlying cause. So there are some just what we would call sleep hygiene or sleep behaviors that are helpful for everybody, and those are good for us all to do, whether or not we have Parkinson's disease, and really regardless of our age, and they will generally help us sleep better and not worse. So what are some of those things? And these would be, again, good for everybody, but generally a consistent bedtime and awake time helps us to sleep better. Trying to avoid napping, or if we need to nap, trying to avoid longer naps later in the day. Those could decrease our sleep drive, make us less sleepy when it's nighttime. Trying to avoid caffeine, especially after lunch later in the day. Limiting alcohol, avoiding nicotine, which could disrupt sleep. Trying to exercise, but just not right in the 2 hours before bed. So exercise could raise our core body temperature if it's right before bed, which could make it harder to go to sleep if it's right before bed. Sleeping in a dark, quiet, cool environment. Avoiding looking at the time if we can't sleep. That can really add to some frustration about not being able to sleep, so just trying not to look at the time. Avoid eating a large meal right before bedtime. That could trigger reflux or other factors. Avoiding electronics in bed. Often they can be stimulating. The light from those might also make it harder for us to fall asleep. And then trying, if we're awake for a really long time, if it feels like a long time, we're having troubles falling asleep or getting back to sleep, often if possible, and I'm going to say if possible, it's better to leave the bed in the bedroom, trying something in another room, and then returning to bed. And we call this stimulus control. And this can be a really important factor because sometimes if we're not able to sleep and we're just tossing and turning in bed all night, our brain can associate that bed as a place to be awake rather than a place to be asleep. Now, with that said, especially if somebody has significant mobility troubles with advanced Parkinson's disease, it might be harder to leave the bedroom, and we may have to modify some of the directions with that we might give to help. So in Parkinson's disease, there can be specific things that can make it harder to fall asleep or stay asleep that folks without Parkinson's disease aren't facing. So there can be some nocturnal motor symptoms. So the tremor of Parkinson's disease typically goes away when someone sleeps. But if somebody wakes up and they don't have as much medicine on board, or their medicine is what we call has worn off, they might notice some symptoms of Parkinson's disease, such as tremors or stiffness, or something called dystonia, where muscles can contract. And that could all make it hard to fall back asleep. So if that was going on, we'd want to try to figure out if we could address this with a medication change with their neurologist. Slowed movements and rigidity could also make it hard at night, or musculoskeletal symptoms if somebody had troubles with stiffness in their joints. There's a higher risk of depression and anxiety with Parkinson's disease. Both of those can make it harder to sleep. If somebody were seeing things called psychosis, that could disrupt sleep. Some dopaminergic medicines could make that more likely to happen. Nocturia, which means having to urinate at night. Men, we can see that with BPH, or benign prostatic hypertrophy. All men with normal aging would be at higher risk for nocturia from that cause, but autonomic dysfunction in Parkinson's disease can also increase the risk for nocturia. We'll talk about something called restless leg syndrome in a minute. That could cause troubles falling asleep, and something called periodic limb movement disorder, PLMD, troubles staying asleep. We'll talk about those. Obstructive sleep apnea, we'll talk about it. That could make it harder to sleep. Nocturnal leg cramps or pain, we'd want to address those if they were occurring. Medications, some medicines can wake us up. Specific Parkinson's disease medicines that tend to be more wake-promoting, selegiline, amantadine, a medicine called istradefylline, which is neurons, and also high-dose dopaminergic agonists can be wake-promoting. And then primary insomnia can also occur. So for managing insomnia, we'd want to address and treat the underlying contributing factors. We'd want to consider a long-acting dopaminergic agonist, such as like carbidopa, levodopa, but in a long-acting form. There are some other things, sublingual apomorphine or an inhaled levodopa, that can be rescue therapy for freezing. And then again, looking at these nocturnal motor symptoms and wearing off. There's a medicine that's FDA approved for Parkinson's disease psychosis, Nuplazid, that could be an option if that's the problem and contributing to trouble sleeping. Cognitive behavioral therapy for insomnia, which is CBTI, is a very helpful tool to help folks with chronic insomnia in general. And that could be helpful, especially if we think it's more primary insomnia that somebody with Parkinson's disease has. There they work on a lot of the sleep behavioral strategies. They may use stimulus control and some other behavioral techniques, including the timing of sleep, to try to improve insomnia. And for the average adult, and especially for the average senior with insomnia, excluding Parkinson's disease, that's first-line therapy over medications. Exercise and bright light therapy may be helpful. Melatonin would be the recommended first-line kind of pharmacotherapy if we had to pick something, if there weren't easy behaviors that we could improve or some cause that we could eliminate. But there are some prescription medicines that we could use with caution. Low-dose doxepin, called Silanor, and Rosarum or Ramelteon could be considered. Rosarum works on melatonin receptors. Many prescription sleep aids, though, could worsen balance, and they might worsen Parkinson's disease motor symptoms or thinking. So restless leg syndrome, it's a sleep-related movement disorder that can contribute to troubles falling asleep, less commonly staying asleep. What is it? It's an unpleasant or uncomfortable urge to move the legs that's worse at rest when we're inactive, and it often occurs when we're sitting or lying down. The symptoms are worse at night. They are at least transiently relieved by movement. It may be accompanied by periodic limb movements, which are little brief movements of the feet where a foot will almost go up when someone's sleeping and then go back down again, that we can see on a sleep study that might wake somebody up. Restless leg syndrome, though, is a clinical diagnosis based on those symptoms and excluding other causes. And again, other causes could cause leg discomfort too, but this is a specific condition that we've recognized that could make it harder to fall asleep, and it can occur in Parkinson's disease. About 20% of it about 20% of patients with Parkinson's disease could have restless leg syndrome. Other things, though, can mimic this. Why we'd want to recognize this, there are some specific treatments for it that might help somebody sleep if this was a cause of their trouble sleeping. 40% of patients with Parkinson's disease, though, will have something similar that will be like nocturnal leg restlessness that might be more of a wearing off phenomenon from their medicines than restless legs. So this would be if somebody kind of felt restless at night with Parkinson's disease, we'd want to really tease that out with their doctor and kind of figure this out. Is this restless leg syndrome or is this a medication effect, so that we knew what treatment we needed to try to employ to get it better. Periodic limb movements are more common than in the general population. Again, those are little brief movements of a leg that would go up about every like 60 seconds in the middle of the night that could cause somebody to wake up more or be more sleepy. How do we get restless legs better? We think regular exercise can help, or how do we avoid it? Some medicines can be causative, antidepressants, some antihistamines, things like Benadryl we've learned can cause restless legs. Caffeine, nicotine can worsen it. We think insufficient sleep or obstructive sleep apnea can worsen restless legs as well. And possibly mental alerting activities may help us to prevent or minimize the symptoms when we do them. So if somebody's concentrating when the restless legs are happening. Warm baths, leg massages, sensory stimulation, and there's something called tonic motor activation, almost like a TENS unit, if anybody's familiar with that, which is like a electrical stimulation that can stimulate muscles, may help restless legs as well. Iron supplementation can be very helpful for restless leg syndrome, and we'll often check iron studies to see if someone's deficient if they have this condition, but iron can often cause constipation. That's a common non-motor symptom in Parkinson's disease, so we'd have to be careful with that. Long-acting dopaminergic medicines we'd consider if we thought it was really more wearing off symptoms. And then there are drugs like gabapentin or similar cousins to it called pregabalin or gabapentin and carbol that could be considered if somebody had restless leg syndrome that might be very helpful. So another class of sleep disorders that could affect anyone, but we look at in Parkinson's disease, would be those associated with circadian rhythm disruption or just disorders. So in this slide, we're looking at two different factors that can impact how awake we are or how sleepy we are. So there's this, it's what we'll call in sleep medicine this two-process model. So the first process for all of us to determine even right now how awake or how sleepy we are is the homeostatic sleep drive. So that's a long word, but basically the longer we're awake, the sleepier we get based on that sleep drive. And if you look at the picture with the blue arrows, if you look on the very bottom here, so this is awake and this is asleep over here. So awake's going to here, and if you see the blue arrows, they're pushing down more and more the longer someone's awake. That's our homeostatic sleep drive. But at the bottom is this other process, and that's our circadian rhythm. And they don't always completely align. So there's this alerting signal from our circadian rhythms, and if you look at this, this is when the alerting signal is peaking, and it sometimes is going higher, almost right when the at different times they're not exactly matching up. And melatonin is made at night. Melatonin basically helps tell our body it's nighttime and is important in our circadian rhythm. So both of those aspects affect how alert or how sleepy we are at different times, and that might be why there can be a little circadian dip after lunch if anybody gets a little tired early in the afternoon. So we know that with Parkinson's disease, we think that there can be some potential changes in the circadian rhythm structures due to the neurodegeneration condition itself, but also possibly just changes in activity level that might affect somebody's circadian rhythm that could affect sleep and alertness. We think that there may be changes in the amplitude of melatonin secretion as well. And then there can be some circadian rhythm disorders if somebody falls asleep too early, called advanced sleep phase syndrome, or has troubles falling asleep until later, called delayed sleep phase syndrome. Obstructive sleep apnea, it's a common sleep disorder. It's caused by recurrent collapse of the upper airway during sleep. Disruptions in sleep occur from collapse of upper airway structures that will cause drops in oxygen, arousals from sleep, and it can affect our sleep architecture. Symptoms that we'll see with obstructive sleep apnea can include snoring, choking, gasping for air. There may be pauses in breathing, daytime sleepiness, frequent awakenings. It can affect our thinking. It can be associated with cardiovascular risks like heart attacks, arrhythmias, strokes, high blood pressure, diabetes. We'll look for it with testing. We can do testing in a sleep lab or at home. They both have some pros and cons and different reasons why we might pick one of the two tests. And then we can try to treat it with things like CPAP. There can be dental devices that can work. Sometimes having somebody avoid sleeping on their back where obstructive sleep apnea is worse can help. Weight loss, if someone's obese, can play a role in helping. There's a medicine FDA approved to treat sleep apnea, which is Zepbound, which is one of the weight loss drugs that it's approved to treat it if obesity is thought to be a cause. And there's something called hypoglossal nerve stimulation called Inspire that can stimulate the nerve to the tongue to make the tongue move forward to create more room in the back of the airway. And then there's some other surgeries. This is a picture just showing a couple of the different diagnostic tests that are, a home test is mainly done right now to look for obstructive sleep apnea. So you can see this gentleman sleeping in his own bed at home. He has a pulse oximeter on his finger. There's a belt that's measuring movement and a little nasal cannula that's helping to check to see what his oxygen's doing at night and if there's airflow. Next to that, there's a depiction of in-lab testing where we'll learn a little bit more. There are more things to it, though. So sometimes it can be harder to sleep in a sleep lab. For REM behavior disorder, the main way we might look for that would be an in-lab testing now, but we are trying to find ways that we might be able to identify that through home testing moving forward. But more things to the in-lab testing, but we can sometimes gain more accurate information. And then just a depiction of obstructive sleep apnea. We have a picture on the left where there's a non-obstructive airway, and you can see the blue coming in the airway here is basically everything is open, and then kind of a depiction of an airway that's obstructed where air can't get through, caused by some of the tissue in the back of the throat. And then CPAP basically gives a pressure of air. That's one treatment for obstructive sleep apnea that can keep the airway open. We think that the rate of obstructive sleep apnea in Parkinson's disease is similar to the general population. There's another type of breathing disturbance called central sleep apnea that can also occur. And we do think, though, that patients with Parkinson's disease are more vulnerable to sleepiness and cognitive symptoms from obstructive sleep apnea than the average individual. There may be some other factors related to Parkinson's disease, including dyskinesis of diaphragmatic muscles that might affect breathing, or slowed movements that might affect it. We do think there are less severe oxygen desaturations in Parkinson's disease than average individuals that may cause some of the home testing to be falsely negative, so just something that we think about as physicians there. And treatment of obstructive sleep apnea with CPAP may improve sleepiness and may improve cognition in anyone, and that could be especially important in Parkinson's disease. And the last condition or symptom I wanted to talk about is excessive daytime sleepiness. So that affects about 1/3 of folks with Parkinson's disease. There's an increased risk of sleepiness with progression of the disease and age. We think that the causes may be multifaceted. There may be several things involved, including wake-promoting structures that might be affected by Parkinson's disease. And then we'd manage it by trying to minimize medicines that might be sedating. Sometimes we can take a medicine that might cause sleepiness at night, take something that might wake somebody up earlier in the morning. We would try to treat any sleep disorders that are present, like obstructive sleep apnea. We would want to treat the sleep disruption from whatever cause it's caused by. If it's severe, we would want to be careful with driving. We want to be careful with driving in anybody that's sleepy. If it's severe, we might need to have somebody not drive in anybody that's very severely sleepy. Bright light therapy is a potential help for sleepiness. Exercise can be helpful. Wake-promoting agents do exist. Modafinil is a medicine, or Provigil, where there is some evidence that it may help the sleepiness in Parkinson's disease. So in summary, problems with sleep are among the most common non-motor symptoms of Parkinson's disease, and they have important consequences. They can affect the quality of life for those with Parkinson's disease or their caregivers, and they can potentially have some negative effects on cognition and mood. And by treating it, we might be able to help things like cognition, mood, and also may help motor symptoms and balance, and possibly decrease fall risks. sleep problems are more complex in Parkinson's disease than in everyone else. But there are important things that we can be aware of as patients and with doctors to try to recognize those and get them better. And by gaining knowledge of this, hopefully this will hopefully help individuals with Parkinson's disease with their sleep, or you with your sleep, and helping take care of patients that have sleep troubles with Parkinson's disease. So thank you very much for your attention, and with that, I think we have some time for questions.
Thank you, Dr. Garwood. We do have a few minutes for questions, so if you have a question, please just raise your hand. I'll make my way to you with the microphone, so you don't need to leave your seat. So hands up, and remind me if I acknowledge you, but then don't come towards you.
Hi, thank you for your talk.
You're welcome.
Curious about bright light therapy. What is that? Is that somewhere you have to go, or is it something you do at home? What is that?
Great question. So bright light therapy. So in general, getting natural light, like now we've got the summer in Michigan, during the day is a good thing for everyone's sleep, and trying to minimize artificial light at night, such as artificial light from such as smartphones or television that might disrupt our circadian rhythm. So when I mentioned bright light therapy, there are light boxes that can be used that are about the size of an iPad. That's not something that we've necessarily recommended for everybody with sleepiness yet, but just in general, light exposure during the day, minimizing artificial light at night might help. But in the winter, if the sleepiness seemed worse, especially where light is more dim in Michigan, light therapy might help. And I think it's an area where we need more research to see if we used light therapy every day in somebody with Parkinson's disease, could that help them be more alert, given circadian rhythm questions.
Thank you. What about salariya at night?
What about salariya?
Drooling,
Excessive drooling at night. Good question. So I guess I would wonder, if someone brought that up to me, I would first question, is it bothersome to the individual? If it is, then what would we do about it? That's a tricky one, because the treatments for it would dry out the mouth. And that sometimes is a common complaint that I'll get with outpatient, just in general in sleep clinic. It would be dry mouth from different things, some medicines too. But there can be some medicines that could actually cause dry mouth that a neurologist might be able to give. If it got severe enough, I'd want someone with Parkinson's disease to bring that up to their neurologist, and they might consider medicines. There are some that might make that better. It wakes you up because your pillow's wet from drooling. Yep. Yeah. So the tricky thing is that a lot of those medicines that could cause dry mouth could really cause quite a bit of side effects. So that's a harder one to completely eliminate. If it got really excessive, because certainly that is a symptom, even that I mentioned, kind of a non-motor symptom that can occur in Parkinson's disease. There could just be different treatments aimed at the salivary glands themselves, and or other things that were what we called anticholinergic medicines that literally cause dry mouth, but we again have to kind of look at it closely and what would be the best one. There's even scopolamine, which is like a motion sickness patch that potentially could be used, but a lot of that could have some other negative side effects. We have to be careful.
More questions? Okay. Well, Dr. Garwood, you did such an evaluative job that everyone has had their questions answered. Thank you so much.
Thank you.
All right, folks, so we are going to take a quick break. We have about 10 minutes. We'll come back together at 2:10.